Hello, my name is Doneen Day, and I am the coding educator for the Surgery Pod. I want to speak to you today about the ICD-10 updates that become effective October 1st. With regard to unspecified codes, the Center for Medicare and Medicaid Services allowed a one-year grace period to adjust to the new coding structure. Regarding the uses of unspecified codes, however, that year is up, and CMS will now expect physicians to document and code with high levels of specificity for conditions that fall within their specialty. Effective 10/1/2016, unspecified codes will not be accepted for conditions that fall within the provider's area of expertise. Some documentation tips include: update your problem list to the most current specific diagnosis. Remove duplicate or conflicting diagnosis. Document according to acuity and the highest level of specificity. Document cause and effect relationships, as well as linking complications to chronic conditions. Probable and suspected conditions should be reported as signs and symptoms until a definitive diagnosis can be made. We have two new codes for neoplasms, hormone-sensitive malignancy status and hormone-resistant malignancy status. Other new codes include carpal tunnel syndrome, bilateral upper limbs. We had right and left, and if it was bilateral, previously you had to use both codes. So now there's one code to say bilateral. We have excessive and redundant skin and subcutaneous tissue. This will be a good diagnosis for our paniculectomies. Post-procedural complications. These codes used to say hematoma and hemorrhage. They've broken these codes out to be hematoma, hemorrhage, and they've added a seroma code. And this is for subcutaneous tissue following another procedure or for subcutaneous tissue following a dermatologic procedure. So these are all individual codes now: hematoma, hemorrhage, and they've added seroma. With regard to facial fractures, they've added laterality, the orbital floor, malar, maxillary, zygomatic, and mandible. Please be specific as to what area of the mandible it is. Again, they just added laterality. That's the only change. In the fracture codes, I just want to remind you of the 7th character for fracture codes. A is for the initial encounter for a closed fracture. B is for the initial encounter for an open fracture. D is for a subsequent encounter for a fracture with routine healing. And G is for a subsequent encounter for a fracture with delayed healing. And then we have K, which is a subsequent encounter for a fracture with non-union, and S for sequela. This is just some review for ICD documentation. We really need you to be as specific as possible with regard to malignancies in the breast and their location. We have a code for the nipple and areola, the axillary tail, the central portion, and then the upper inner quadrant, the upper outer quadrant, the lower inner quadrant, the lower outer quadrant, and overlapping sites. Especially for our surgery coders, they really need to know exactly where in the breast the malignancy is located. If it spreads to more than one area, please feel free to use overlapping sites. Again, we will not be getting reimbursed if we use unspecified codes, so we really need for you to specify that location. And of course, we have laterality left and right. I don't think that's a problem. We usually know which breast we're working on. And then with regard to pressure ulcers and ulcers, we need you to be as specific as possible with the location there as well. Lower leg is not enough. The codes are broken out into thigh, calf, ankle, heel, and midfoot. And then we have elbow, upper back, lower back, sacral region, hip, and buttock. Then there's contiguous sites, back, buttock, and hip. And of course, there's always laterality left and right. But again, especially with the lower leg, we really need that specification with regard to the location. And then the staging for pressure ulcers, we need that as well. Unspecified is not going to be accepted We have stage 1, which is a pre-ulcer with skin changes limited to persistent focal edema. We have stage 2 with abrasion, blister, partial thickness skin loss involving epidermis and or dermis. And then I'm guessing 3 or 4 of the stages that we would deal with more. Stage 3 is a full thickness skin loss involving damage or necrosis of the subcutaneous tissue. And then stage 4 is necrosis of the soft tissue through to the underlying muscle, tendon, and bone. So even if you don't document the actual stage, we need to know how deep the ulcer is. If it's a full thickness that only goes down to the subcutaneous tissue, or if it actually goes through to the underlying muscle, tendon, or bone. So please be as specific with that as possible. It's crucial. That's all I have for now. Please feel free to contact me. I'm usually available. Thank you for your time.